Hey everyone, Dr. Shahid here, and in this video, we're diving into an important topic in restorative dentistry, cavity prep and bonding. Whether you're working on a simple filling or a more complex restoration, your preparation and bonding are key to making sure your work is strong, long-lasting, and successful. Let's get started by reviewing the different caries classifications, which ultimately dictate how a preparation will be performed. Class 1 cavities are found in the pits and fissures of posterior teeth, such as molars and premolars, or you can find them on the lingual grooves of anterior teeth. The preparation here is typically confined to the occlusal or lingual surfaces without extending to the marginal ridges. Next, we have Class 2 cavities, which occur on the proximal surfaces of posterior teeth. Now, since it's tough for us to directly see these areas, you're gonna need radiographs. As for the prep, we have to remove the contact point between the teeth. That's an important consideration when restoring Class 2 preparations. Class 3 cavities are located on the proximal surfaces of anterior teeth, and they don't involve the incisal edge. On the other hand, Class 4 cavities are the same as Class 3, but they do involve the incisal edge. In these cases, the preparation will obviously be more extensive. And finally, we have Class 5 cavities, which occur on the cervical surfaces near the gum line of both anterior and posterior teeth. Alright, now that we've discussed caries classification, let's quickly talk about important preparation principles that you need to be aware of. In general, preparations require a caval surface margin of 90 degrees. This maximizes enamel bonding and provides structural integrity. For superficial caries, we focus on removing all infected and affected dentin to create a clean surface for bonding. However, for deep caries, it's a bit different. Here, we remove only the infected dentin while leaving affected dentin in place, because affected dentin can actually be remineralized. And to aid in that remineralization, a calcium hydroxide or glass ionomer liner is typically applied. Not only will this help to remineralize the affected dentin, but it'll also act to protect the pulp and provide a stable base for the overlying composite restoration. Alright, now let's talk about something very important that's more or less specific to Class 3, 4, and 5 restorations. It's none other than the enamel bevel. Creating an enamel bevel after caries removal has many advantages. It essentially increases the number of enamel rods available to us, which not only results in better adhesion for our resin composites, as the enamel surface area we have available for bonding has now increased, but it also leads to a better aesthetic result. So always make sure to create an enamel bevel for these restorations. Okay, and now we'll talk about the magic behind adhesive dentistry, bonding. Bonding is essentially a micromechanical and/or chemical union between resin and tooth structure. It results in increased durability, retention, and resistance to microleakage. So needless to say, we rely on bonding to a great degree. Now, bonding to enamel and dentin work in slightly different ways. In the case of enamel, bonding relies primarily on micromechanical forces, whereas for dentin, micromechanical forces are complemented by chemical bonds between the bonding agent and the collagen fibrils located within dentin. This is a bit of an important topic, so let's zoom in and take a closer look at how all of this works. And we'll begin with dentin bonding. So here we have a cross-section of freshly cut dentin, and the first thing you'll notice is all the gunk. It's very difficult to see this clinically, but this is the smear layer, and it clogs up the dentinal tubules and prevents us from forming a strong bond. So first things first, we need to get rid of this gunk, and we can do that with good old phosphoric acid. Thorough rinsing of the phosphoric acid etch will leave a nice clean network of exposed collagen fibrils and open dentinal tubules. Now the key to keeping these collagen fibrils nice and plump is to ensure they remain hydrated, because excessive drying with the air-water syringe will cause these collagen fibrils to collapse, which will in turn weaken the bond we're able to create, and it'll increase dentin sensitivity. So don't over dry. We want some moisture present within the collagen network so that the fibrils can stand tall and plump as we see here. Alright, at this point we've set the stage for the application of our bonding agent, which will not only incorporate into the dentinal tubules, but also within the collagen network. We call this the hybrid layer because it's the zone that's composed of both dentin and resin. So once we cure our bonding agent, we're going to be left with our superficial oxygen inhibited layer, which is primed to interact with our overlying resin composite. And that's dentin bonding, guys. It's easy to forget this stuff once you're in practice, but remembering it will allow you to make crucial clinical decisions when things don't seem to be going our way. Alright, Now let's turn our attention to enamel bonding. Enamel bonding is actually much more simple than dentin bonding. So here we have a cross-section of freshly cut enamel rods, and the first step to preparing the surface for bonding is the exact same as before, etching with 35% phosphoric acid. This will effectively dissolve inorganic substances such as hydroxyapatite crystals on the surface of exposed rods, which will create microporosities and increase the surface area we have available for bonding. And so enamel with high mineral content will lead to a stronger bond since acid etching will create more microporosities on the surface. And the last step will be application of our bonding agent, which will interlock with the rough surface we've created for a long-lasting micromechanical bond. Alright, now I want to mention a quick bonding complication, and it's with regards to a condition I actually talked about in the last video, hypocalcification. If you guys remember, hypocalcified areas appear as white spot lesions, similar to demineralization. The thing you'll want to remember here is that bonding to hypocalcified enamel isn't as good. And that should make intuitive sense because, as I mentioned just a minute ago, enamel with high mineral content leads to a stronger bond. So conversely, it makes sense that enamel with low mineral content, as is the case with hypocalcified enamel, leads to a poor bond. And with that, we're ready to reinforce everything we just learned with a practice problem. Okay, so we have a 50-year-old female with the following chief complaint. The filling I got last week is very sensitive. Background on her patient history reveals hypertension and asthma, and current medications include albuterol, aspirin, hydrochlorothiazide, and triamterene. Current findings indicate sensitivity on number 13 MOD composite restoration. We also have a radiograph to go along with all of the information. Okay, so the question reads, what is the most likely cause of the sensitivity the patient is experiencing? Read all of the option choices, make sure you understand them, pause the video if you need, but the answer is excessive drying of dentin prior to bonding. So the filling on the radiograph actually looks pretty good. And although option choice A can be a source of sensitivity, the radiograph doesn't seem to indicate a filling that's encroaching on the pulp. So in this case, it's more likely for the sensitivity to be due to excessive drying of dentin. Now, option choice C, secondary caries, or recurrent caries as it's sometimes referred to, is also unlikely since the filling was just done last week. And finally, excessive etching of enamel isn't a source of sensitivity. And with that, we are done, guys. As always, here's a quick list of high yield points that I went over in this video. Thanks for watching and see you next time.